what a great time it is to be treating patients with kidney cancer. 6 years ago, this would have been a very short talk. The idea of neoadjuvant or pre-surgical therapy for patients with locally advanced and metastatic disease would have been laughable. But now we have a whole plethora of different agents, almost to the point of an embarrassment of riches, where now the idea of neoadjuvant therapy can be realized, and perhaps patients will do better integrating surgery with systemic therapy, both in the locally advanced and metastatic setting. These agents were developed as a consequence of an increase in our knowledge about the biology of kidney cancer at the molecular level. And while certainly increased response rates have been realized with these agents, ultimately patients will develop resistance, and I think it therefore solidifies the need for surgery to be integrated with systemic therapy, both in the treatment of locally advanced and metastatic disease, but how best do we integrate those two together? Well, at MD Anderson, we've been studying the concept of neoadjuvant and pre-surgical therapy for the treatment of kidney cancer. There are potential benefits associated with this approach, including possible primary tumor downstaging or downsizing that may make surgery easier. As we've heard about the importance today of nephron sparing, it may allow us to increase the utilization of this technique. It may make the unresectable resectable and improve prognosis. In patients with metastatic disease, it may eliminate or downsize the metastatic tumor burden, and may also allow us to use this technique as a litmus test to only operate on those patients best likely to benefit from surgery. There are potential risks, including increase in surgical morbidity. It's possible that the patient may not respond to the targeted therapy and in fact progress locally or metastatic while on therapy. And it's possible that the therapy may actually alter the biology of metastatic or local disease in an adverse way. We conducted a trial using bevacizumab in the pre-surgical setting. This was published back in 2009. And then recently conducted a trial with sunitinib in the pre-surgical setting for patients with metastatic disease. Currently, we have ongoing a trial with axitinib in the neoadjuvant setting for patients with locally advanced disease, where they receive 3 months of axitinib followed by curative nephrectomy with RPL&D. Just as we've heard about the importance of nephron sparing, partial nephrectomy had several hurdles to jump before it could be accepted as equivalent to radical nephrectomy in the treatment of patients with kidney cancer. It had to demonstrate equivalent cancer control, it had to be nephron sparing, and I would argue that the least important factor is the idea of being minimally invasive. Well, neoadjuvant therapy has several hurdles to jump as well. First, it has to be safe, there has to be lack of disease progression or increased surgical morbidity, it has to improve patient outcome, and I would argue that primary tumor downstaging or downsizing would be a benefit, but it's probably the least important factor to be considered in this approach. So first, is neoadjuvant therapy safe? Well, these are 2 patients that have been treated at our institution with neoadjuvant therapy who had complete abdominal wall dehiscences 3 months after surgery, just to remind us of the potential for wound complications associated with this approach. So we did a retrospective review of patients with metastatic disease, 70 of whom were treated with pre-surgical therapy, and compared them to 103 patients who were contemporary who underwent immediate cytoreductive nephrectomy. And what we found was that the patients who received pre-surgical therapy did not necessarily have an increase in the complication rate associated with pre-surgical therapy. However, they were more likely to have delayed complications, and if they had complications, they were more likely to have more than one complication, and they were more likely to have wound complications relative to the group that had upfront surgery. And here in multivariate analysis, the only factor that predicted for a wound complication in this population was receiving pre-surgical therapy. However, in multivariate analysis, receiving pre-surgical therapy was not predictive of an overall complication in this group of patients, whereas performance status and locally advanced T-stage were. So then we asked the question, okay, if patients who receive pre-surgical therapy are more likely to have a wound complication, perhaps we can predict which of those patients are more likely to have that wound complication and take steps at surgery to perhaps prevent it. And much like the talk by Dr. Peter Clark yesterday regarding nutritional status and surgery, we found that those patients who had a decline in serum albumin while on pre-surgical therapy were more likely to have a wound complication, and now use this as a parameter to study these patients and perhaps do things at the time of surgery to enhance wound closure. But in terms of predicting overall survival and comparing these 2 groups, we were heartened to realize that receiving pre-surgical therapy was no better and no worse than patients who had upfront cytoreductive nephrectomy followed by targeted therapy, as shown here in this graph. We've all seen this paper, which is somewhat provocative, in which mice that received short doses of targeted therapy either at the time of tumor implantation or after tumor implantation were noted to have higher tumor burdens and an increased rate of metastasis and decreased rate of survival when compared to mice that did not receive the short course of targeted therapy. And although there are a lot of methodological issues associated with this study, it certainly does give one pause. Well, I recently had a patient that also gave me pause. This was a patient, 81-year-old gentleman, who had bilateral renal masses that enrolled in our axitinib trial. And you can see on the left-hand side, he had a locally advanced tumor involving the left kidney, and also a rather large tumor involving the mid to upper portion of his right kidney. He went on to receive axitinib for 3 months and really had a great response. He had complete reduction in the size of the tumor on the left-hand side. You can see here that that was amenable to partial nephrectomy, and an equally significant reduction in the size of the tumor on the right-hand side. Again, amenable to partial nephrectomy. Well, he went on to have a left partial nephrectomy, and then a CAT scan was obtained about 4 weeks after surgery to be sure that his left kidney was functioning and to get a picture of the right kidney before surgery. And you can see that there was dramatic progression of that tumor on the right-hand side, and although we were still able to do a partial nephrectomy, and he still had bilateral T1B disease, it certainly gives one pause as to the effects of these agents in the pre-surgical or neoadjuvant setting. What about primary tumor downstaging or downsizing? Classically, we're taught in the era of immunotherapy that patients who are treated with their primary tumor in place never respond to systemic therapy. Well, we've all seen these pictures in the literature. This is a patient who was treated with sunitinib and had dramatic reduction in their primary tumor and nodal disease and went on to have a laparoscopic nephrectomy. And again, these are patients that have been treated on our neoadjuvant axitinib trial. You can see dramatic reduction in the primary tumor after 3 months of axitinib, and this was the specimen. Here's another patient that was treated with neoadjuvant axitinib. Again, dramatic reduction in their primary tumor, and this was the specimen. So my question is, are these just anecdotes, or can we rely on these agents to reliably downsize or downstage tumors? Because if we can, I would argue let's give them to everybody, and then we could do nephron sparing on everybody. But what's the data? One of the first papers published on this was out of the Netherlands, where 17 patients were treated with sunitinib pre-surgically, and the response rate was only 23% with a 31% volume reduction. Brian Reeney's group published data looking at sunitinib in patients treated with their primary tumor in place, and again, you can see that the vast majority of patients had little, if any, response in their primary tumor. These are data from our bevacizumab trial, again, demonstrating little, if any, response in the primary tumor. And these are data out of North Carolina where patients were treated with sorafenib, and although there were some dramatic regressions and some dramatic progressions, the vast majority had little, if any, response in their primary tumor. We recently published our experience on looking at 168 patients who were treated with their primary tumor in place for a variety of different reasons as shown here. And what we found when we looked at all of these patients who were treated with a variety of different targeted agents was again that same story, that the vast majority of patients had little, if any, response in their primary tumor. As was pointed out in one of the earlier talks regarding reduction of IVC thrombi, many patients in the community with IVC thrombi are started on targeted agents with the idea that it will shrink the thrombus and make the surgery easier. Well, we had 48 patients in this series who had an IVC tumor thrombus, and you can see from this data that the vast majority of these patients had little, if any, response in their IVC thrombus as a consequence of treatment, and in fact, 15% of patients progressed on the therapy. So I would argue that the initial body of evidence would suggest that primary tumor downstaging is not going to be realized with the current generation of agents. So I would argue that pre-surgical therapy is safe. We can deal with wound complications. It does not reliably downsize or downstage tumors, so is this a treatment advance? I would argue yes. In our pre-surgical bevacizumab trial, there were 50 patients that were enrolled, but only 42 patients actually underwent surgery, and 6 patients had disease progression and went on to salvage systemic therapy rather than surgery. So I would argue they were safe from a surgery they were not likely to benefit from. We recently did a study where we looked at whether or not the primary tumor response could be used as a biomarker for outcome in patients with metastatic disease. What we noted was that those patients who were treated with their primary tumor in place, the vast majority responded usually within the first 60 days. And in fact, those patients who had a greater than 10% response within the first 60 days went on to have a fairly significant response in their primary tumor. So we looked at 75 patients who were treated with their primary tumor in place with a median follow-up of 15 months. And what we noted was that those patients who had a greater than 10% response in their primary tumor, particularly within the first 60 days, had a significantly better survival than patients that did not. And in multivariate analysis, that greater than 10% response held up, especially when it occurred within the first 60 days. And we were heartened to realize that colleagues in the Netherlands, or Axel Bex, was able to demonstrate the same thing and arrive at the same conclusion independently. So in conclusion, neoadjuvant therapy for renal cell carcinoma, I would argue that targeted therapy has dramatically improved the outcome for patients with metastatic disease, that efficacy in the adjuvant and neoadjuvant setting is still under investigation, that without complete responses, surgery will remain an integral part of the treatment of patients with both locally advanced and metastatic disease, and that pre-surgical or neoadjuvant therapies may have merit but need further study and validation. So where do we go from here? Well, we recently held a conference at GU ASCO where Bernard Escudier and I chaired a meeting where we discussed the concept of neoadjuvant therapy. There are many controversies associated with this approach, including which agent should we use? I would argue, based on our data, axitinib. What should be the inclusion criteria? Should it be locally advanced disease? Should it include nodal disease? Should it be metastatic disease? And what is the endpoint? I would argue that probably the most objective endpoint is reduction in primary tumor size, but others have argued the ability to perform nephron sparing might be a suitable endpoint. And recurrence-free survival has also been argued, but that would be quite a large trial. At the end of the day, what we concluded was that we need more data, either with sequential or perhaps randomized phase 2 trials to identify the best agent for phase 3. Thank you for your attention.